Hello everyone. The topic of today's discussion is glandular odontogenic cyst. So we'll be covering the topic under the following headings. When we talk about the definition of a cyst, it was first defined by Kramer in 1974 as a pathological cavity which may have fluid, semi-fluid or gaseous content which is not formed by the accumulation of pus. They are frequently but not always lined by epithelium. So cyst is a cavity which can have fluid, semi-fluid or gas. If it is lined by a cyst, then it is known as a true cyst. Otherwise, it is a pseudocyst. Scheer has given the classification of the cyst into two broad categories, the epithelial line cyst and the non-epithelial line cyst. So today we'll be discussing glandular odontogenic cyst, which belongs to the category of developmental origin. So it is an odontogenic cyst of developmental origin and it is an epithelial line cyst. So when we talk about a cyst, cyst has three major components. First is the wall or the capsule of the cyst. Second is the cystic lumen. And the third is the epithelial lining. So a cyst is comprised of the epithelial lining, the cystic lumen, and the cystic wall and the cystic capsule. When we talk about the origin of the cyst can have origin either from the cell rest of Serrae, that is rest of dental lamina, or it can be from rest of Malassez or from reduced enamel epithelium. The cysts which take origin from reduced enamel epithelium are dentigerous cyst and eruption cyst. Those cysts which take origin from cell rest of Serrae are odontogenic keratocyst, gingival cyst of newborn and adults, little periodontal cyst, and glandular odontogenic cyst. And from rest of Malassez, the cysts which take origin are periapical cyst and residual cyst. So the topic of today's interest is glandular odontogenic cyst. So it is a cyst of epithelial origin, which is developmental in origin, and it takes its origin from cell rest of Serrae or remnants of dental lamina. Now, starting with the introduction of glandular odontogenic cyst, it is also known as cyalo-odontogenic cyst because it shows both the features of a salivary gland as well as odontogenic epithelium. Also, it is known as mucoepidermoid odontogenic cyst. So, because it shows some histopathological resemblance to mucoepidermoid carcinoma of intraosseous variety. So it has two names, either cyalo-odontogenic cyst or mucoepidermoid odontogenic cyst, based on its appearance and its presentation. Now, when we talk about glandular odontogenic cyst, it is an unusually large, it can be solitary or it can be multilocular. It takes its origin from cell rest of dental lamina and it consists of stratified squamous epithelium lining, which can have numerous mucus secreting cells. It is a rare lesion and it shows aggressive clinical behavior. Although we have discussed that it is of odontogenic origin, but it has both the features of the glandular or the salivary structures as well as it shows odontogenic rests also. So this indicates the pluripotential nature of the odontogenic epithelium to exhibit both glandular differentiation as well as odontogenic cyst appearance. So this term cyalo-odontogenic cyst was first discovered by Badachi and Wenwick in 1987. Then Gardner in 1988 discussed that it is known as glandular odontogenic cyst or GOC. Then in 1992, it was accepted by WHO, and in the WHO histological typing, now this distinct entity is known as glandular odontogenic cyst. When we talk about the frequency, it is a rare lesion. In about 6 cases have been reported out of a series of 3,498 cases. And when we talk about the percent, only 0.2% of all jaw cysts are of GOC variety. When we talk about the age and the gender predilection, the peak frequency is seen in the 6th decade, although there is a wide age range from 10 years to 90 years, and the mean age is 49.5 years. These lesions show slight male predilection. More cases are seen in males in comparison to females. Now, when we talk about their clinical presentation, the most common site which is seen to be affected is the anterior mandible. The lesion is usually slow and progressive in nature. Initially, the lesions are painless and they are locally destructive. When we talk about the site comparison, mandible is found to be more commonly affected in comparison to maxilla, and in mandible also, anterior mandible is more frequently affected. This is an aggressive tumor, as we have already discussed. Either it is being kept in the aggressive cystic lesion variety or in potentially aggressive cystic lesion variety, and there has history of reoccurrence if it is not adequately removed. In the earlier lesions, it will be a painless swelling of the jaw or face, but in the later, when there is progression of the lesion, it will become painful. We have already discussed that the majority of the cases have been shown to be present in the mandible, and that too side predilection for anterior mandible. Also, GOC has a characteristic feature to cross the midline. So whenever it is being asked that multilocular lesion crossing the midline, the most likely differential diagnosis is glandular odontogenic cyst. Also, the cystic size can vary from very small lesion to about 1 centimeter in size. Also, it can be a large destructive lesion. Depending upon the stage and the clinical presentation, it can be asymptomatic or it can be associated with pain and paresthesia. When we talk about the radiological feature, it can be unilocular or multilocular, but it will have well-defined borders. So in some cases, the borders can be sclerotic or they can be scalloped. Also, there can be associated root resorption and tooth displacement in cases of GOC. So when you see a unilocular lesion, there will be a large unilocular radiolucence area with corticated or sclerotic margins. When we talk about multilocular lesion, there will be extensive lesion. So there will be large multilocular radiolucency with a sclerotic or scalloped margins. So coming on to the histopathology of glandular odontogenic cyst, this cyst is lined by non-keratinized stratified squamous epithelium. The thickness may vary. In some area, it can be showing epithelial thickenings and plaques. In some areas, it can be reduced enamel epithelium-like. Also, this lesion will have pluripotential nature. So in some areas, we'll be having microcystic spaces which are opening onto the surface, giving corrugated appearance. Also, in some other areas, we can see glandular structures with goblet mucus producing cells. So in this histomicrograph, we can appreciate the non-keratinized stratified squamous epithelium of varying thickness. The epithelium shows papillary and the corrugated appearance in the superficial layer. The interface between the epithelium and the connective tissue seems to be flat, and there are multiple microcysts and intraepithelial crypts which may or may not have mucus, and they are opening onto the superficial surface. Also, in some areas, we can appreciate thin epithelial lining which may resemble to that of reduced enamel epithelium. In high power view, we can appreciate the papillary and the corrugated appearance of the epithelium. The epithelium shows both the cystic differentiation as well as glandular differentiation, and there will be presence of goblet cells which are mucus producing cells. Also, in the histopathology, we can appreciate some intraepithelial crypts and microcysts which may or may not have the presence of mucus. Another important histopathological feature for GOC is the presence of hobnail cells. These are superficial layer cells which are cuboidal to columnar cells. Also, they can have cilia or filiform extensions. In the histopathology of GOC, we can also appreciate columnar and pseudostratified epithelium with goblet cells. So we have the flat interface between the epithelium and the connective tissue. The cyst wall is usually devoid of inflammatory cells, and the characteristic feature of GOC is the presence of hobnail cell and the papillary and the coagulated corrugated surface. And when we see the histopathology, there is an histopathological overlap between GOC and the intraosseous variety of low-grade mucoepidermoid carcinoma. So to differentiate these two broad categories, the glandular odontogenic cyst will show variable thickening of the epithelium. There will be plaque-like areas, whereas in cases of mucoepidermoid carcinoma, there won't be any presence of these thickenings. When we talk about the lining, GOC has a characteristic feature of superficial eosinophilic cuboidal cells or the hobnail cells, which are not seen in cases of MEC. There will be presence of intraepithelial microcysts and crypts, which are absent in cases of mucoepidermoid carcinoma. In glandular odontogenic cyst, there will be epithelial whorls, sperules, knobs, which are not seen, Whereas when we talk about the histopathology of mucoepidermoid cells, there will be presence of epidermoid cells, clear cells, mucous cells, and intermediate cells. These cells are found to be absent in cases of GOC. Also, when we compare the stroma of these two varieties, in cases of GOC, the stroma will be hyalinized and it will have dense collagen bundles. Whereas the cases of MEC will have multicystic spaces. Also, there is immunohistochemical differentiation. GOC will be positive for CK19, whereas mucoepidermoid carcinoma will show positivity for CK18. So this is a differentiation marker to rule out whether it is glandular odontogenic cyst or central MEC. Now, there was a criteria given by Kaplan, which shows that we should find histopathological features in two broad categories, that major criteria and minor criteria. If these are seen in the histopathology, then only we can give the confirmatory diagnosis of glandular odontogenic cyst. These features are the presence of non-keratinized stratified squamous epithelial lining with flat epithelial connective tissue interface, the presence of spherules, knobs or whorls in the proliferations, also presence of hobnail cells in the superficial epithelium, and the presence of multiple intraepithelial crypts with mucus or goblet producing cells and mucus within these crypts. Also, there were some minor criteria as given by Kaplan, that these are the papillary proliferation of the epithelium, the presence of ciliated cells, multicystic or multiluminal architecture, or the presence of clear or the vacuolated cells. So these are the criteria which are being given so as to give the confirmatory diagnosis of glandular odontogenic cyst. When we talk about the treatment, if the lesion is small and it is unilocular, they are usually enucleated before histopathological confirmation, and they should be followed for at least 3 years. If the lesion is large and it is multilocular, then they should be biopsied first and then treatment planning should be done. Now, to summarize, when we talk about glandular odontogenic cyst, they are also known as cyelodontogenic cyst and mucoepidermoid odontogenic cyst because they show the differentiation of both the cystic variety as well as the glandular structures, and they have a histopathological overlap with intraosseous variety of mucoepidermoid carcinoma. The lesions can be large solitary or they can be multilocular. They are derived from cell rest of Serrae or from the rest of dental lamina. It is usually an aggressive or potentially aggressive cystic lesion. These lesions show predilection in males. The peak frequency is seen in 6 decades. When we talk about the site, mandible is more frequently affected in maxilla, and that too in the anterior mandibular region. Also, GOC show the feature of crossing the midline. Initially, the lesion can be painless swelling. In the later stages, it can become painful. They can be unilocular or multilocular. So they will be reducent lesion surrounded by a sclerotic, well-corticated margin. When we talk about the histopathology, the epithelium shows non-keratinized stratified squamous epithelium of varying thickness with papillary or corrugated appearance. There can be presence of intraepithelial crypts and microcysts, which may or may not have mucus. Also, the interface between the epithelium and the connective tissue is flat, and in some areas we can appreciate reduced enamel epithelial-like lining. Also, one of the characteristic feature of GOC is the presence of hobnail cells in the superficial layer. Thank you.